No, the previous one, please. Yeah, thank you. No, the next. This doesn't seem to work. Yeah. So a lot of what I will be talking about will be found on our website, and I will encourage all of you to please have a look at it, because the solutions that we work are aimed to be evidence based. So they are not just a capacity building exercise based on evidence that is found outside the country, but rather building evidence from that local context that we work in. They have to be context specific. So you have heard about the launch of the HiCap project, which will build evidence on how antimicrobial stewardship will be done in 6 hospitals, and then will scaled up to the rest of the country. If they are cost effective, there are measures for economic costs that will be measured, and they are sustainable because of the partnership with the local research groups as well as the Ministry of Health. The change that will be brought about is not restricted to those 6 hospitals that we work in, but will move beyond. And we have already talked about the One Health spectrum and bridging evidence to policy. Next slide. So this is a map just to show you where we are. We started with only 2 or 3 countries, when 2 or 3 staff members. Today we are 25 countries strong, with almost 55 projects that you can see are spanning across the globe. They are located in Africa, in Asia, in Latin America, and also East Europe. And the pictures that you see here signify the sectors these projects are in. That means many of them are in poultry or the animal sector, in pigs, and in human health sector. So you will see the human being measured, and some also in the environment. Many of them are also cross-sectoral or beyond a sector in terms of like communication for AMR or gender and antimicrobial resistance talk that should be happening and is missing at the moment. So this is a list of the projects we have on our website, and this list is increasing. And we are very glad that 2 of these projects are currently in Cambodia, and we hope to have this partnership becoming longer with more projects. Next slide, please. So how do we work? As I explained to you, and I'll just take a short while to explain this slide, we have a top-down and a bottom-up approach. So when we say bottoms up, we engage with the local researchers. Like in this case, we have the National Institute of Public Health, which is the premier research agency and public health agency in the country, working with the Ministry of Health, which is the implementing arm of the government, together talking about a project they would like to build on, which is antimicrobial stewardship, based on the previous work that has been done with for example, the National University of Singapore, the World Health Organization, and building further evidence base to inform policy. So this work is very collaborative. And when we say top down, we engage with the Ministry of Health. So we are grateful. We have a partnership with the Ministry of Health through a signed memorandum of understanding, and that commitment that the ministry has declared in the National Action Plan, that stewardship in the hospitals is of prime importance. So this approach of being top down and bottom up helps to position ICARS as a catalyst, which we hope will gather evidence from the ground and help scale up solutions that can work for AMR. Can I have the next slide? So I'll briefly talk about antimicrobial stewardship, but I will skip some of these slides because in the previous pre-lunch session, we've had a very good discussion on what is antimicrobial stewardship, which is basically a measure to persistently measure and improve practice. And this can be done not just at a hospital level or a country level or a province level, but even at an individual level. And I think we had a very good question today and discussion that antimicrobial stewardship is also not restricted to human health. It could be in animals, in the farms that we are in. It could be in the environment, in it being a reservoir and the antibiotics or the genes that enter the environment. But the idea is to measure and inform practice. So if I can go to the next slide, antimicrobial stewardship projects in hospitals primarily aim to use the principle of quality improvement. And in quality improvement, many of you who are coming from the hospitals would already know, we have the concept of PDSA cycle, which is plan the intervention, do it. So implement it in terms of quantitative measures and behavior change and cost. Study that impact. What is the change that has been brought about by the behavior change or the practice change? And then finally, after measuring the impact, whether it has been useful or not, act again by adjusting the intervention for what has worked and what has not worked. So this is a continuous cycle. And remember, if you do not measure something, you can never change or improve it. So this is the key principle of antimicrobial stewardship. And we hope through this project, we will also apply it in the hospitals. Next slide. So in ICARS, when we work on antimicrobial stewardship or any other solution for AMR, we have this concept of intervention and implementation research. And this, you can find more details on a paper that has been published by our team. But the essence is that for assessing the evidence of an intervention's action, we must look at the outer setting, which is the health system, the political and economic scenario, and the cultural context in which that intervention is being rolled out. So, for example, in our project, it's going to be the health landscape in policies that are important for antimicrobial resistance, but maybe as simple as hospital management, health-seeking behaviors, the expenditure on a health sector, etc. And in addition to that outer setting, sorry, can you go back? We must look at the inner setting, which is the actual areas or 6 hospitals where the antimicrobial resistance intervention is going to be implemented in terms of the structures, the hierarchy, the culture, and the readiness to get a change. And while we design the intervention, we measure the impact in both the inner setting and the outer setting and work closely with the stakeholders who may be involved at both the inner setting and the outer setting level. This whole process is assessed during the implementation period, where we have different work packages that will work to design the intervention and measure its impact in terms of hospital practices, behavioral and economic practices, and policy landscape. So you could read more details about our IIR framework, but this is the crux of most of the projects that we currently implement. If you go to the next slide. So what is antimicrobial stewardship? Again, I'll not spend too much time here, but we must remember it's about optimizing the use with precision and balance. And the World Health Organization also gives these key principles of AMS, which include strong governance systems, very good antibiotic management, and that is from input to output prescribing practices, having guidelines and recommendations which are essential for how healthcare practitioners should actually work and know what is the correct practice and what is incorrect. Having an education and training on those guidelines and recommendations, and finally, monitoring, evaluation, and feedback of what is being done to make sure that the effect is being reached or to do a course correction. If you go to the next slide. So here I have discussed already about AMS a little bit. What I'd like to spend some time is to give examples of what we are doing in other parts of the world. One of the projects which we are very proud of and has been our first project, one of the first projects, is about optimizing antimicrobial use in bloodstream infections and urinary tract infections in key hospitals in Zambia. This has been over 3 provinces, from the tertiary care to the secondary care structure. And the partners for this project are Ministry of Health, which is again the implementing agency in a country, but with them, the University of Zambia Teaching Hospital and the Zambia National Institute of Public Health. And this team has a team of researchers who are ID physicians, clinicians, pharmacists, who have been working and monitoring the treatment and management of BSIs and UTIs in the hospitals. They have come out with increased compliance to treatment guidelines, which were designed, appropriate use, and change in costs, as well as recommendations for the ministry. If you go to the next slide. Next slide, please. Yeah, we have some very interesting results because this project is still wrapping up. There has been almost a 10% reduction in patients being prescribed multiple antibiotics. So from many antibiotics, they have gone down to 1, which is evidence-based. Treatment guidelines were developed for managing BSIs and UTIs, and the compliance has definitely increased. Prescription of multiple antibiotics has decreased. by almost 6.5%, and the categories of antibiotics had a drastic change. This, I think, is one of the key measures because most of the antibiotics they were earlier prescribing were watch category, which is where we would like to decrease use unless there is requirement, and then prescription of a tertiary care of a reserve antibiotic like ceftriaxone has also seen a reduction. The project is now wrapping up the end line results, so we hope to have a lot of publications coming out soon from this project. Next slide, please. This is a project in Malawi that has just started about rationalizing antibiotic use in, again, bloodstream infections and UTIs in patients, but in a different context. Here, our partners are the Ministry of Health, but including them, we have the AMR-CC per se, which is the AMR Coordination Committee, and one of the universities, which is Kamuzu National University of Malawi, as well as Longway Medical Trust, which is an NGO working in that sector, all coming together to design the project to characterize the current practices, which is by a baseline survey, and then designing an intervention that can work for the settings where we will be implementing the project. All throughout intervention implementation research, two things for ICARs are essential. One is monitoring and assessing the behavior change in prescribers or patients. And second, monitoring the economic costs for AMR and getting evidence to make sure we make a good justification that tackling antimicrobial resistance is valuable for health. Can I go to the next slide? There are many examples that I could share, but I have kept a few here, and I would encourage you to go to our website. One project in Europe, Central Europe, is on antimicrobial stewardship for surgical site infections. And this is a project being implemented in Georgia with the Ministry of Health, the National Center for Disease Control and Public Health, like their premier institute, and the central hospital in the ministry, as well as the healthcare professional network and WHO Europe. So as ICARs, we try to collaborate with all the existing partners where possible and not redesign something that is already being implemented and can be useful for the field. The study has shown that the 60% compliance to the SAP guidelines that were developed for antibiotic prophylaxis for the surgeries within a year of launch, and the assessment of the prevalence of the surgical site infections was useful to develop the guidelines for their management, which has improved the context for the physicians to understand why not to give too many antibiotics for cover and how to de-escalate and make sure that IPC and prescription guidelines are a match, and there is no need to prescribe antibiotics if IPC standards are maintained well. Can I go to the next slide? So I will pause here because I have not kept too many examples, but we have many other stewardship examples from human health, but also animal health. And as an ongoing partner with Cambodia, I would encourage you to have a look at our website and also track the webinars and community of practice that we try to build with all the team members who are located in these countries to develop capacities and work to strengthen solutions that can work for AMR. Thank you so much for your patience, and I'm happy to take questions whenever it's possible.
នាងខ្ញុំសូមអរគុណដុកទ័រជូទីសម្រាប់បទបង្ហាញកម្មវិធីបន្ទាប់គឺជាបទបង្ហាញពីបទពិសោធន៍កម្រិតអន្តរជាតិនិងតំបន់ក្នុងការអនុវត្ត AMS ដែលបង្ហាញដោយលោកបណ្ឌិត Alvin Shaw អ្នកស្រាវជ្រាវមកពីសាលាសុខភាពសាធារណៈ Soshi Hook នៃសាកលវិទ្យាល័យជាតិសង្ហបុរីសូមគោរពអញ្ជើញ
Hi everyone. Good afternoon. Thank you very much for your patience. It's both an honor as well as a privilege to be standing here in front of everyone. I would like to first express my gratitude for the opportunity to speak to you guys today. My name is Alvin, and I'm a research fellow from the Saw Swee Hock School of Public Health in National University of Singapore. Together with me today from NUS is Professor Su Yang, who is sitting over there. He will be part of the panel later during the discussion session later. So I am here now to kind of share with you what a typical AMS antimicrobial stewardship service is like in Singapore. This is building upon what Professor Bori mentioned earlier on in the context of Cambodia. So I just want to have a disclaimer to say that this is largely based on my experience as an AMS pharmacist in a large public hospital in Singapore prior to joining Saw Swee Hock School of Public Health. This is back in 2019. So with regards to the outline of my presentation, I will briefly go through what AMS is about, but I believe you guys already have an idea. Then I will move on to talk about how the AMS team in Singapore General Hospital, where I was working at, is like in terms of the operations. And then I'll share some collaborations with Cambodia since then. So what is AMS or antimicrobial stewardship? You probably have heard this like multiple times today. So antimicrobial stewardship refers to a series of coordinated interventions that are aimed to improve and to measure appropriate use of antimicrobial agents by promoting the selection of optimal antimicrobial regimens, including the choice of the therapy, the dosing, duration of therapy, as well as the route of therapy. Yeah, so overall, the major objectives of antimicrobial stewardship are to limit the selection of pressure on bacterial populations that drives along emergence of those resistant strains and to prolong the lifespan of these life-saving antimicrobials. In addition, antimicrobial stewardship aims to achieve best clinical outcomes for the patients and also to minimize toxicity as well as other adverse events and to reduce excessive costs attributable to suboptimal antimicrobial use. So what are some antimicrobial stewardship strategies that can be used? Firstly, let's talk about the prospective audit and feedback, which helps us to allow us to review antimicrobial use on the patients in a real-time basis and to guide prescribers towards best practices. Then we also, subsequently after that, we will streamline the antimicrobial therapy by looking at dose optimization or perhaps conversion from IV to oral therapy. Then there is also formulary restriction and pre-authorization, which will help to limit unnecessary use of these broad-spectrum agents, while at the same time, antimicrobial order forms standardize the prescribing at the way doctors prescribe and to reduce errors. And education is pretty much foundational to empower clinicians to have the knowledge so that they know which are the best antimicrobials to prescribe. And this is largely done through guidelines, clinical pathway development, which provides a clear roadmap for evidence-based decision making. So overall, all this set of tools, I would say, is helpful to improve patient outcomes, reduce resistance, and safeguard the future of antimicrobial therapy. But I will reiterate all this again in the example of Singapore General Hospital in the next few slides. So prior to joining Saw Swee Hock School of Public Health, as I mentioned, I was an antimicrobial stewardship pharmacist in Singapore General Hospital. So SGH is one of our nation's leading academic health sciences center and a major tertiary hospital. And it's pretty much serving both the adult as well as the children population. And as of 2023, it houses about close to 2,000 inpatient beds at that point in time. Overall, SGH offers a comprehensive spectrum of medical specialties from internal medicine to surgery to even ICU disciplines, ensuring high quality multidisciplinary care. I would also like to just share that we have a full microbial laboratory service that kind of help to support our antimicrobial services. So then our AMS team, when I was still there, was largely consist of the following three roles, which is infectious diseases physician, the clinical pharmacist, as well as an executive. So we had three physicians, one executive to help with the operations of the team and also in terms of data management, while the rest of the team is made out of mainly clinical pharmacists. But do note that beyond these three roles, there are quite a number of other roles that are essential or could be added on to your antimicrobial stewardship team as well. So these include things like clinical nurse, the microbiologist, epidemiologists, people from the infection control profession, or perhaps even IT staff as well. So just moving on to some activities conducted in Singapore General Hospital, our team pretty much plays a pivotal role in guiding appropriate antimicrobial use through this prospective audit and feedback system, ensuring that the prescription aligns with the what is being recommended. At the same time, we add on formulary restrictions so that it helps us to control the use of these high-risk medications. Beyond all these clinical roles, we also have things like education and antimicrobial guideline development. And also, eventually, we will monitor and evaluate all these outcomes that we have been collecting so that they eventually generate into reports that are useful for the end users, as well as perhaps being publication in international journals as research. So I'll just quickly talk about the audit and feedback system. So this is what it looks like on a day-to-day basis for antimicrobial stewardship pharmacists. So the day starts with looking at the number of the list of patients who have been started on antimicrobials 24 hours before, in the last 24 hours, and this is being pulled up by the IT system. And then the AMS team will then review the patient case to look at whether the antimicrobial being prescribed is appropriate or not. So this is looking at whether there's even a need for the antimicrobial to begin with, and if it's intended, then is it the correct choice, correct route, correct dose, correct duration, so on and so forth. So after this primary review, if there is any doubts or anything, the pharmacist will then refer this case over to the ID physician, who will then discuss, they will discuss it during an afternoon meeting to kind of see whether this case is appropriate or not. And in the event that it's not, the team will then provide an intervention feedback in the form of a letter to the physician to kind of say like, hey, your antimicrobial use is inappropriate. Would you perhaps consider using something else, for example? So some of the interventions that are being done would be, some of them Dr. Bori has already mentioned before. So things like discontinuation of antibiotics, in dosing optimization, changing from IV to PO, de-escalation or escalation, and also even some other things such as further investigations. Perhaps we would recommend them to go for more scans, for example, or to do some blood samples to be sent for cultures, or even things like referral to the infectious disease specialist, and also infection control measures if we think that there is a chance of outbreak. So over here is just a sample of the intervention letter, a blank template that can be used to write what we want to convey to the primary team. So this slide here is exactly the same as what I've described before, but I just wanted to highlight that all the data that is collected is being pulled into a central database where we can look at the data and to kind of analyze it to see trends over time, which will then help us in terms of the reporting. So beyond this clinical role, as I've mentioned earlier on, we do a lot of other things such as education campaigns. So what you can see here are posters that have been put up in the hospital at various locations for the public. So this sends a message whereby the antibiotics are not being useful for cold and flu, and to push for vaccination instead. At the same time, we also have some other campaigns, for example, like the IV to PO conversion therapy, for the physicians. So we mentioned things like if they actually consider switching over to the oral version, it is easier to administer, there are less likely risks of adverse events, it is probably cheaper, and at the same time, the patients have a more likelihood of being discharged earlier than if they were being put on the IV therapy. So there are also guideline developments. So over here, we can see that we have developed the guidelines according to the different type of infections. And also there's a surgical prophylaxis guideline as well. And this is being placed in the hospital's intranet. But at the same time, because we want it to be accessible by as many people as possible, we have it in a hard copy booklet format, as well as a mobile application format as well. Yeah. So beyond that, as I've mentioned earlier on, we have monitoring and reporting of the outcomes, and then these are then subsequently converted into potential reports and research. So some of these performance indicators that are being sort of collected, right, would include the following over here. We look at things like antimicrobial consumption rates, including whether the antimicrobial use is appropriate or not. And after that, we also look at other things such as intervention acceptance rates, because this is important to see whether what we say to the primary physicians matter or not in their opinion, and if they do not accept our interventions, what are some of the common reasons why they do not accept it? For example, like are they uncomfortable with our suggestions, or perhaps they just think that the patient is already improving on the current therapy, so they do not want to change it. Yeah. And we also look at post-intervention appropriateness rates, because we want to see that whatever we've done has resulted in changes, right? So overall, beyond all these things, we also look at patient outcomes to ensure that patient safety is not compromised. So things like mortality rates, reinfection rates, readmission rates are being considered as well. And you would have heard of cost savings from the earlier presentations earlier on about how antimicrobial stewardship interventions can help reduce the cost of all the various antimicrobials being used. And of course, we also look at overall antimicrobial resistance rates, although this is a little bit of a far-fetched concept. So overall, all these things have been sort of put up in international publications. So over here, you can see a particular article on antimicrobial consumption and cost savings. You probably will not be able to see the words here, but once the slides are being disseminated out, you can have a look at them. Then there is another one that looks at patient safety, as I've mentioned before. And this article actually mentions that those physicians who accepted our AMS intervention, their patients did not perform worse than those whose interventions were not were rejected, essentially. Yeah, and overall, we had a period of time where we wanted to push for the use of procalcitonin to kind of differentiate between bacterial and viral infections, because for bacterial infections, this will kind of push the level of procalcitonin in the blood to be high. So if we know that the patient has a normal or the procalcitonin level is not elevated, then it's unlikely to be a bacterial infection, and thus antimicrobials can be stopped. So over here, the publications you can see is in different patient populations, including those with unspecified sepsis, those with malignancies, as well as those with pancreatitis. So yeah, beyond that, there are some other initiatives that have been done. As mentioned, we've looked at the impact of antimicrobial stewardship programs. We've also moved along with times and developed IT tools to improve antimicrobial prescribing appropriateness. So this comes in the form of CDSS, which is the Clinical Decision Support System, whereby physicians can just input the patient's diagnosis or what they think the patient has, and then the system will kind of churn out recommendations on the antibiotic and the dose for that patient. We are also moving towards AI, which, I mean, not we, but I've already left the organization, but my ex-colleagues are still working on AI projects to kind of help with the diagnosis of selected disease states, pretty much similar to what Dr. Bori has shared earlier on. They are also looking at the PK and PD of antimicrobials, and at the same time to see therapeutic drug monitoring of these antimicrobials as well. For example, like the aminoglycosides, vancomycin, as well as more recently the beta-lactams. And for multi-drug resistant organisms, the team has been looking at combination testing of various antimicrobials at various dosages to ensure that these MDROs are being sort of eliminated effectively. And they are also expanding towards fungal diseases as well. Yeah, so this point prevalence survey, you would be familiar. We have also contributed data to the global point prevalence survey on antimicrobial use. So we're able to look at things like which are the type of wards or the department that have the highest antimicrobial prescribing. We could also see what are the top sort of users for these antimicrobials in terms of the indication, and also some of these quality indicators such as whether they wrote down the reason of starting the antimicrobials in the notes, or whether they have a stop review date for that particular antimicrobial. And this is trended over time so that we can see exactly which are the areas that we can target and to improve on. So this is the last part of my presentation. You would see this photos being a little bit familiar. We have been working together with CalMed Hospital for quite a while now, since 2019, and this was the first few initial meetings, at least for me, on antimicrobial stewardship and point prevalence survey. And these are just photos of us doing data collection during point prevalence survey, as well as discussing the results of our pilot session. And we've also been working closely with the team from DHS, Prof. Subun and his team, as well as Peg and his team from Kana, with regards to the point prevalence survey exercise across Cambodia, as you guys would have heard from him earlier on before, and also Dr. Bori. And also working together with them to kind of work on various policy documents, the policy, curriculum, and guidelines with the support of WHO. So that's all that I have for now. If you have any questions, comments, please let me know, or you can contact me at any of these platforms over here. Yeah, thank you very much.
នាងខ្ញុំសូមអរគុណដល់លោកបណ្ឌិតសម្រាប់បទបង្ហាញតទៅនេះប្រសិនបើឯកឧត្តមលោកជំទាវលោកស្រីមានសំណួរអ្វីអាចសួរមកខាងក្រុមការងារបានចា៎សូមអរគុណ
ចានាងខ្ញុំដុកទ័រសុផានីខ្ញុំមានសំណួរទៅដុកទ័រ Alvin ខ្ញុំសូមសួរជាភាសាអង់គ្លេស So I have two questions to Dr. Alvin. Yes, the first question is about the challenge as the clinical pharmacist who working in the hospital. How you could convince the doctor to change their practice, because I know that it's not easy. It's not easy. Like some doctor they think that why the pharmacists come to ask us to change the treatment or something like that. So we would like to hear from you about your challenge and how you can overcome this problem or something like that. And the second question is about how the MS team in Singapore General Hospital convince the director to support, because as I know that you have a lot of team, like I think it's more than 10 people, and have to be like a strong support from the director of the hospital to have like a huge team like that. Thank you.
Hi. Yeah, thank you very much for the questions, but I believe these questions will be asked again in the panel discussion later. So, yeah, but with regards for the first question in terms of the challenges in sort of convincing the physicians about our efforts and why is a pharmacist coming over to step all over your territory and deciding on what to prescribe and what not to prescribe, right? So, we definitely had a rocky start at the beginning. In terms of having a lot of these physicians who are more senior in position compared to us, being not willing to sort of listen to us and to follow what we suggest. Largely because they will say things like, why are you bothering me? This is my practice all along and it's been working all along. So why do I need to change it? But of course, with persistence and showing them all this data from positive cases that have worked and trending all this data across time, across different departments. So you kind of have a sort of like a benchmark to see who are the people who are performing better and who are not performing as well. And with all these various sorts of evidence that we can present to all these hard to reach physicians, they slowly over time, they would kind of be a little bit more open-minded as well. And I would say, as we move along, when the newer generation comes in, they are more open and accepting to our ideas. So that makes things a little easier as well. So definitely one thing is to present them with sort of hard evidence why this works, including things from international journals and our own evidence. Then the other one is to be persistent on our efforts and to keep driving the same message over and over again, even though it's tiring. And eventually, I guess you would also kind of need to find an AMS champion in each of these other departments to kind of support your efforts. Mainly to show them that, hey, we are not here to step over your territory, to invade into your space, but we are here to hold your hands, to walk together with you, to ensure that we get the best patient outcomes for our patients together. Yeah, so in that way, I think over time it would make things easier. But as I've mentioned, my experience only lasts until 2019, so it's been like probably 6 years since then. So things might have changed even for the better or maybe for the worse, I'm not sure. Yeah. And I think your other question is with regards to how do we get support in terms of governance from the directors and all that, right? That question would be a little bit hard to answer, but I think maybe Li Yang might have a better idea. I think we have funding from the ministry, if I'm not wrong. Is that right? Yeah, so.
Thank you. So initially, after showing that antimicrobial stewardship was important, there were a group of us that went to the Ministry of Health and said, you have to give the hospitals money to start this program because the people are already working full-time and are busy, and without the additional resources, they wouldn't be able to do it. So the Ministry of Health was somehow generous at that time, and they gave money to the hospitals to run this program as a special budget. And then eventually it got included into the overall budget for the hospital. So we have been lucky. The hospitals have additional funding to hire doctors and pharmacists to run the antimicrobial stewardship program, depending on the size of the hospital and also depending on the success or needs of the hospital.
ចាលោកគ្រូអ្នកគ្រូមានសំណួរអីទៀតអត់ទេបើអត់មានទេនាងខ្ញុំសូមចូលដល់កម្មវិធីបន្ទាប់ចាកម្មវិធីបន្ទាប់គឺជាកម្មវិធី Panel